The phenomena I'm describing has a name. In the surgical orthopedic literature, it's called Arthrogenic Muscle Inhibition, AMI. It was first formally described in the ACL literature. Surgeons noticed after anterior cruciate ligament injury, even after textbook surgical repair, the quadriceps would lose measurable voluntary activation. Not weakness in the sense of atrophy. The quads was structurally fine, but the patient could no longer recruit it in the way they used to. Their nervous system had turned it down. It has since been documented in the ankle, shoulder and post-surgical knee literatures. It is one of the most replicable findings in conservative orthopedic research, and yet outside surgical rehab, it is barely used clinically. This is the gap, or that is the gap. Here's how it works, in the cleanest version I can give you. When a joint takes an input, an injury, a strain, an inflammatory event, a build-up of repetitive load, sometimes even a residual signal from an old event that has long since healed, the joint receptors in the joint capsule and surrounding ligaments fire abnormal signals into the spinal cord. Those signals reach spinal interneurons, and the interneurons does something very specific. It downregulates the motor neuron pool that supplies the muscle responsible for stabilizing that joint. The result is a muscle that is structurally intact, anatomically normal, but neurologically inhibited. The contractile machinery is there, the wiring has just been turned down. This is not a slow atrophy-driven weakness. It is fast. It happens within seconds of the joint input arriving. And it is reversible, but only if you address the input that is driving it. If you do not address the input, you can strengthen the muscle by working around the inhibition for years, and it will keep being neurologically turned down underneath your strengthening work, which is exactly what we see in clinic. So what does that mean for what you do on Monday morning? It means that if you are not testing your patients for currently activate neurological inhibition, you are doing structural treatment on top of neurological problems. You may get results, you will sometimes get a long result, but you will not consistently get durable results because you have not addressed the upstream signal. It means that your patient on slide 4, the recurrent SI joint, the stubborn tendinopathy, the runner's knee that does not settle, is in a meaningful percentage of cases walking around with neurological inhibition that nobody has tested for. And it means that the most powerful thing you can do before you adjust, before you release, before you load, is test. Find what the nervous system is currently allowing. Find what it's not. Then decide what to treat, which brings us to the test itself.